Welcome back to the PR interview for ESOC 2023. My name is Linxin Li. I am the chair of the PR committee for the conference. It's my great pleasure to welcome Professor Bart from the Netherlands, who is the PI of the Precious trial that we're going to discuss next. So Precious was presented yesterday in a plenary session which looked at prevention of complications to improve outcome in elderly patients with acute stroke. So Bart is going to be interviewed by Professor Christine Roffe, who is Professor of Stroke Medicine at Keele University in the UK. So welcome Bart and Christine, and over to you.
Thank you.
Oh, congratulations on finishing and completing a study which is so difficult during the pandemic, and getting patients recruited and getting comprehensive and results which we can act on. So just tell me, what was the idea of the trial and why did you choose the interventions you chose?
Thank you, Christine. We assessed whether a pharmacological strategy to reduce the risk of infections and fever improves outcome of elderly patients with moderately severe to severe stroke. And these pharmacological strategies were very simple and safe and inexpensive. These consisted of paracetamol, metaclopramide, an antiemetic drug, and ceftriaxone, an antibiotic drug, which is frequently used in patients who have post-stroke pneumonia.
There are a number of antibiotics of choice. Why did you use ceftriaxone?
Across Europe, and at least in the Netherlands, where I come from, ceftriaxone is the preferred antibiotic for patients with post-stroke pneumonia.
Because in the UK, where we're not allowed to use ceftriaxone because of higher risk of C. difficile infections. So we were quite surprised, and I think some of the UK centres had problems with recruiting patients.
Yeah, and fortunately we proved that the risk of these Clostridium difficile infections is very low if you use ceftriaxone.
Why did you use paracetamol?
Because it's safe and inexpensive and widely available across the world. And because in a previous study, also performed in the Netherlands, it was shown that at least in patients who had the highest risk of developing a fever, this might improve outcomes.
Yeah. And the metaclopramide, why did you choose that?
Because of your MAPS trial, which showed that in patients with a nasogastric tube, the chance of having a pneumonia is much smaller if you use metaclopramide.
So what outcomes did you take for the study, the main outcomes?
Yeah, the main outcome was actually the score on the modified Rankin scale at 90 days. So the usual outcome in acute stroke trials.
So we want to know whether patients have a better outcome, whether they've got a better life afterwards.
Yes.
You also had an outcome of pneumonia. Did you?
That's correct.
Yeah.
We also had pneumonia was one of the secondary outcomes, and we assessed this both as diagnosed by the treating physician and as diagnosed by an expert panel.
Yeah. So you've got safeguard on
Yes.
quality.
Yeah.
Just tell me what the main outcomes were of the study.
Yeah, unfortunately, none of the medications had any effect on functional outcome at 90 days, which came a little bit as a surprise to me, because I'd, of course, hoped, but also expected that at least one of these medications would be of benefit. Now, remarkably, ceftriaxone nor metaclopramide had any effect on the risk of developing a pneumonia. Mm-hmm. So this was all quite disappointing, to be honest.
But I suppose it can also be a positive thing. We've all been worried about the antibiotics. So we've got a real response. There have been so many trials on antibiotics. And I think at some point you want to know that really they work or they don't. And I think your trial has really told us that there's little point in using antibiotics.
At least preventive antibiotics.
Preventive antibiotics, yes. So I think that's really an important response. The other thing which I found interesting is that the infections were reduced and UTI was reduced, but there was no effect on pneumonia. How do you explain that?
Yeah, probably as has been suggested by others earlier, post-stroke pneumonia is maybe to a large extent a chemical process caused by aspiration early after a stroke, and that maybe bacteria play only a little role in the development of a post-stroke pneumonia.
So you've been shown that the antibiotics do work because they've reduced the infection, but that for pneumonia you need something else. And I suppose that brings us to the metaclopramide.
Yes.
You found that the metaclopramide neither reduced pneumonia nor did it do anything good for survival or quality of life. So tell me, any ideas why that might be the case?
No, actually, I have no idea, because this was, now, as I told you, I had expected that this would at least have an effect on the risk of pneumonia. I personally think that this is caused in part by the fact that patients have aspiration very early after stroke onset in the first few hours, and that we can maybe prevent aspiration at later points in time, but that the patients already have this aspiration before we start the trial treatment. And this is also something that has been shown by one of my PhD students, Jeroen de Jonge, who has shown that in patients with acute stroke, many already have signs of pneumonia on a CT scan of the lungs in the first few hours after symptom onset.
Have you looked at that, at the timing within, because you recruited within 24 hours, have
Yes.
you got any data on that? That early treatment is any different than late?
Yeah, there was no difference whether treatment was started in the first 6 hours, in the first 12 hours or later.
One of the major differences between your study and the MAP study is obviously that you used the treatment for 4 days,
Yes.
whereas the original study treated for 3 weeks. Do you think that could have had an impact on the outcome?
I would certainly recommend to continue the study in the UK for, I think you use 2 weeks in this trial. So I would certainly not stop this study based on the results of Precious, because it's different. It's a different study with indeed a different duration of treatment, and we chose this shorter duration of treatment because according to the SMPC of metaclopramide, the preferred duration of treatment is 5 days. You've shown earlier that a longer treatment is safe, but we didn't want to have problems with the regulatory authorities about the duration of our treatment.
Yeah, but I suppose the risk of pneumonia does persist.
Yes.
So it may very well be that, and that's one thing we may find out in due course.
Absolutely, certainly in the patients with the more severe strokes.
Yeah. Do you think age made a difference? You obviously selected a group which is at very high risk of pneumonia, the older people. Younger people are less likely to get that. Do you think that could have had any other effects?
No, that's just speculation. One thing we found is that only very few of these older patients developed a fever. Only about 5% in the control group, and paracetamol did reduce the risk of fever to only 1%. But of course, the proportion of patients with fever was so small that this is probably one of the reasons why paracetamol didn't have an impact on outcome.
Could there have been interactions between the treatments which had an effect on the effectiveness of one or the other?
Of course, we checked for interactions and we didn't find interactions between the treatments, so not relevant interactions.
Was the study powered to look at the interactions?
No. It was the groups were too small for. It was just powered to assess the effects of medication in each of the treatment stratums. So paracetamol versus no paracetamol, etc., and not the combination of treatments. These were just we considered these just hypothesis generating, but because the trial was stopped prematurely, the groups were just too small. So I think these analyses are actually of little use.
But I suppose it was stopped prematurely, but you've got so decisive results
Yes.
that you've had your result, isn't
Yes.
it? You didn't actually need any more patients for answering the questions you wanted answering.
My personal idea is that I think that if the trial would have been much larger, we would also not have found an effect, but of course you never know.
Yep,
Yes.
you wouldn't know that.
No, absolutely. Congratulations again on such
Thank
an
you.
important study, and thank you very much for watching, and I hope you have a nice evening.